Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And on our podcast this year, we are introducing a new series that we're calling Heart to Heart. In this series, we'll be speaking with patients and the healthcare providers who treat them. Our hope is that you'll be encouraged and empowered by their stories, whether you are a survivor, a healthcare provider, or a supportive family member or friend. So thanks for joining us on this episode of Heart to Heart. Welcome to another episode of Heart to Heart, where we speak with cancer survivors about their experiences managing both cancer and cardiovascular complications that can sometimes arise during or as a result of their cancer treatment, sometimes before cancer therapy, as we'll hear today. It's a delight to have with us again today Dr. Susan Dent, who is a regular host on this series. Welcome, Susan.
Thank you.
Happy New Year. We are also joined by Dr. Vijay Rao. Dr. Rao has served for many years as the Director of Cardio-Oncology at Franciscan Health in Indianapolis, Indiana. Go Hoosiers. Excited for their first national championship next Monday, we're hoping.
Yes, indeed.
But Vijay has recently moved to Ascension Health, and he's going to be developing a new cardio-oncology program there. So welcome, Vijay.
Thank you so much.
Did I get that right? Ascension Health?
Yeah, Ascension St. Vincent.
Great. Well, welcome. We're so glad you're with us. And of course, we're very pleased to have with us our special guest, Lee Ramsey, who is actually a longtime patient of Dr. Rao. And they have walked together through the journey of cardiovascular disease as well as cancer therapy. So welcome, Lee. Thanks for joining us today.
Oh, thank you. It's my pleasure.
Well, why don't we start, Lee? Just tell us a little bit about how it was that you first met Dr. Rao. I know that in your case, you actually started working with him as your cardiologist prior to cancer diagnosis. Tell us a little bit about how that all came about.
Sure. In December of 2012, I had spine surgery in Tampa, Florida. I live in the Indianapolis area, but traveled to Tampa for the surgery. Coming out of the surgery and recovery, just had a heavy chest feeling. The team in recovery put an ECG on me and saw irregularities in my heartbeat, or my rhythm of my heart was concerned. They had me transfer me to Tampa General, where I was checked for a heart attack, which was negative. Had other tests done, including the next day a nuclear stress test, where they discovered the left bundle branch block. So I was sent home, and I think it was just a week or two later, I don't have an exact timeline, I met with Dr. Rao, connected with them as a result of being an inpatient care provider in our network. So when me and Dr. Rao went through various tests, and Dr. Rao add anything or make corrections, going from notes from many years ago, another nuclear stress test, E-scan of the heart, an MRI of the heart, and wore a Holter monitor for a period of time. And I had diagnosed a low ejection factor, I believe in the mid-30s, treated with carbidool, lisinopril, is managing exercise, and then a year later diagnosed cancer.
Maybe, Lee, I can expand upon that a little bit. Can you tell us how that you came upon that cancer diagnosis and a little bit about what that cancer diagnosis was?
Sure. This week in January in 2014, I was traveling on a business trip in Nashville, Tennessee. And the early part of the week, I started noting just some unusual bruises on my body, some open blood, kind of almost like a blood blisters inside my mouth. As the week developed, I started getting more and more bruises. And honestly, by the middle part of the week, it looked like I'd been in a fight with Mike Tyson. I was just covered in bruises for no reason. I wake up in the morning, had bruises everywhere, as well as having a red rash on my legs below my knees. Traveled home on Thursday, I believe it was, met with the nurse practitioner at my doctor's office on Friday morning. When she saw the spots in my leg, or the petechiae, she was quite concerned that, it may be a sign of cancer. They drew blood. I received a call that next morning at 8:32 in the morning from my family doc at the time, Dr. Shoemaker, letting me know that I had leukemia. I had a very high elevated white blood cell count, a deadly low platelet count, and that I needed to get to the emergency room immediately. And he goes, I don't mean in an hour. He said, literally immediately. So my wife and I went to Franciscan Hospital in Mooresville, where we live. They confirmed the diagnosis through a blood test, transferred to the Franciscan campus on Emerson and Stop 11 Road, admitted into the Indiana Bone Marrow Transplant Group, IBMT for short, where they again confirmed my diagnosis. Sorry, a bit tough going back through this. I went through journals and took notes over the weekend, but you can imagine emotionally, even 12 years later, it still resonates with me. The doctors were very concerned about how they were going to be able to treat me based on the heart condition I had, especially the low ejection factor and left bundle branch block.
Yeah,
Mine-
maybe I can
Yeah.
jump in just real quick there.
Please.
So obviously, when I first met Lee, it was with regard to this new left bundle branch block and this cardiomyopathy. And we did an extensive workup looking for causes for that. This is all, of course, prior to the cancer diagnosis, and ultimately settled on an idiopathic cardiomyopathy, which is what we basically say when doctors don't know what caused the cardiomyopathy. It's the idiot and pathetic doctor who can't figure it out. So we were looking for concerns for myocarditis or inflammation of the heart. We were looking for, any genetic conditions. We were looking, obviously, the most common causes of heart dysfunction are due to coronary disease, but Lee was a young, healthy individual, so it was unlikely that was the case. And we'd had the CT scans and nuclear stress tests and whatnot. And ultimately, we really weren't able to come up with a specific diagnosis, but fortunately, we do know that with medical treatment, with several different medications, as Lee mentioned, carvedilol, lisinopril, a couple of blood pressure pills, they kind of tamp down the neurohormonal system and can improve heart function. So we had started him on some of those medications, and we're starting to see some response, even by the time he was starting to move into the new diagnosis of his leukemia. We were at a place where we were, at a fairly stable point. And I think one really important part of it is that despite the cancer diagnosis, from a heart perspective, we often talk a lot about functional status. So there are folks who are very limited when the heart is not pumping well in terms of what they can do. And at this point, thankfully, Lee was really pretty active and still able to do most of what he wanted, which is a really good prognostic sign from a cardiovascular perspective. So that's kind of the background on the cardiac side of things, kind of going into the new diagnosis of leukemia.
So that's really challenging, Lee. I mean, you were dealing with a cardiovascular diagnosis, which it sounds like through medication, you were able to manage, but then you developed leukemia. Can you tell us a little bit about what were they thinking of in terms of your treatment? And then VJ, maybe you can talk a little bit about the challenges of adding on that treatment in someone who already had pre-existing cardiovascular disease.
Sure. I was diagnosed ultimately with acute lymphoblastic leukemia, Philadelphia positive, basically childhood leukemia. The doctors at IBMT, one in particular, Dr. Luke Akers, one of the pioneers in developing treatment for that program, is a very aggressive treatment of chemotherapy for, I think it was in the hospital for 35 days and discharged and going back to the hospital every single day for additional treatment, whether it be transfusions for platelets or red blood cell count, additional chemo treatments. The one key thing two key things that I really attribute my success or my health for being here today is Dr. Rouse said I was active prior to being diagnosed with cancer. The day my wife and I went into the fourth floor at IBMT at Franciscan, it's a U-shaped wing. And we walked in, many of the patient doors were open and the rooms were dark, blinds were closed, and the only light on was the light above the IV equipment and such on by the patient, and they were laying in bed. And I turned to my wife at that moment and said, this will not be me. I'm going to be active. I'm going to be out of my bed, and we're going to fight this. And starting that day and every day I was in the hospital, I would get up in the morning with the nurses and doctors' approval, grab my IV pole, and would do laps in this U-shaped wing, whether it be if my body only allowed 10, 15 minutes, or there were days where I was able to do up to an hour of walking. No speed walking by any means, but just walking back and forth. And, family members came up every day and friends, and they'd always walk with me. And that and, strong will of God, I think, is the reason I'm here today.
VJ, what were the challenges for you given that cancer diagnosis in terms of, adjusting or modifying the treatment related to Lee's cardiovascular disease? We haven't heard exactly what drugs that you received, but I'm sure some of them would be impact that your cardiovascular health. So maybe you can just speak to that about the challenge, because I think, From an oncologist perspective, we often focus just on the drugs. And as oncologists, we often get a little bit worried when we see people with pre-existing cardiovascular disease that we can actually treat them appropriately with the best cancer therapy available for that disease. So maybe you could speak a little bit about that.
Yeah. So going in, I think with a pre-existing cardiomyopathy, the biggest concerns I had were obviously the treatment that he was going to be receiving. Specifically, are there anthracycline-based therapies? Are there other types of therapies that could lead to a cardiomyopathy? So those are some things that you had to have the discussions with. In this case, I don't believe that was the case. So number one is, good communication with the oncology team about what are the specific treatments. Are there particular cardiovascular toxicities associated? Particularly with a cardiomyopathy, the things I worry most about are arrhythmias and precipitation of what's called congestive heart failure. So fluid overload that can develop. And as Lee mentioned, he's getting a lot of transfusion. So there's a lot of blood, there's a lot of platelets. And in somebody whose cardiac function is not normal, they are much more likely to develop fluid buildup in their lungs and develop arrhythmias secondary to that. Definitely important was monitoring him on the telemetry to make sure that he wasn't having any arrhythmias during all the time he was there. The other thing that we really have to watch out for is hypotension. So with low counts and anemia, oftentimes patients' blood pressures will tank. They'll get quite low. And meanwhile, the medicines we have to protect his heart lower blood pressure. So I know we've had to adjust over the years, but even around that time, we would have to back off on things that we never really wanted to stop everything if we could, because there was still that cardioprotective ability. So it's a tricky scenario. I think, definitely communication with Dr. Akert and his team, who were fantastic, to try to make sure that, one, we do whatever we can to minimize the amount of cardiac toxicity with the specific treatment he was getting and be able to manage through all of the potential complications that occur. So I think just honestly having that kind of communication was key to having success.
Lee, you mentioned that, we saw those dark rooms and you were determined sort of to get up and walk around the hallway and not to be lying in bed all day, which of course, would be better for you from a cardiovascular standpoint. How did you manage having, a pre-existing cardiovascular disease and a cancer diagnosis at the same time? I mean, that must have been really challenging for you, particularly, given that you were younger, you were faced with this, as you said, cancer diagnosis usually associated with younger individuals.
Right.
What were some of the struggles that you had with balancing those two diagnoses?
It's hard to say. I don't want to downplay the cardiac condition, but I think once I was diagnosed with cancer, my focus switched completely to fighting and recovering from cancer. I wanted to make sure I could walk my daughter down the aisle one day. And that was my sole focus through this entire thing. I will admit there are periods of time during this where my memory is not so clear. So I don't know exactly where I may have been thinking one day or the other as far as being concerned about my heart or the focus. I think the focus was really 100% on the cancer diagnosis, and I let the focus on my heart health stay with the doctors.
I think what you raise is so important because, as people are aging, we are seeing more individuals with a cancer diagnosis who have pre-existing cardiovascular disease. And I think the communication point that was raised is so important because I also hear of individuals where oncologists are a little bit hesitant to treat individuals for their cancer because of the worry about their pre-existing cardiovascular disease. So again, it comes down, I think, to that communication and realizing that you do have to individualize treatment plans based on an individual's history, past history, current history, that, one treatment doesn't fit all. So it's really that working together as a team to try and find the best therapy available for someone based on their individual circumstances. Now, I also understand you developed a friendship with your bone marrow donor. Can you tell us a little bit about how that happened and what that was like?
Yeah, absolutely. So I did have a stem cell transplant in June of 2014. Very blessed to have had multiple options, according to my doctors, for donors. And when you have a stem cell transplant, you can sign paperwork on whether or not you want to release your information after a specific period of time. You and your donor can connect. I signed the information. Apparently my donor had as well, but I never heard from him until gosh, it was over a year later. It was in November of within 2015, where she woke up one morning, opened my computer, but had an email from my donor. Probably my paperwork, he got lost, and then he eventually made its way through. And his name's Ed Farmer. He lives in the Chicago area. And he said in the email, I don't know if you wanted to connect or not, but I just wanted to reach out and say hello and hope you're doing well. And amongst other things, a very emotional email. And then just a little month later, my wife and daughter and I went to Chicago, met Ed and his wife, and become very close friends, almost a brotherhood. So we stay in regular touch and get together at least once a year, and with our families or just individually go to a Cubs game or something fun like that.
That's great. It's so wonderful to hear that. I'm going to flip over now to Vijay and ask you, obviously, Lee, you got through your stem cell transplant and we talked about the challenges during treatment, but what about after treatment? So you're dealing with that pre-existing cardiovascular disease and cardiomyopathy, and then you go through treatment for your cancer. Vijay, what concerns do you have from a cardiovascular standpoint about following individuals after completion of their cancer therapy and the potential long-term complications of these therapies on cardiovascular health?
Yeah, for sure. We see each other about once a year, and ultimately, we were able to get complete normalization of his heart function actually post-transplant. So that piece was really important. And that happened fairly quickly. And, I think a large part of it was just the willpower, frankly, of Lee and his faith. And I think the fact that, he stays active. So ultimately, we have had these conversations about de-escalation of cardiac treatments. And there's a lot of literature out there now, particularly in these cases of, where we don't know what caused the cardiomyopathy, that the medications that seem to improve things often need to be continued lifelong. There have been multiple recent papers that have shown that if you withdraw too hastily the medications, that patients' cardiomyopathy can come back to the same level, in fact, sometimes worse than before. So, we always have, Lee and I have that conversation about the risks and benefits of staying on treatment. Obviously, he's doing so well and so active, and we'd like to de-escalate. And so we've been, negotiating, I think is probably a good word, every time we meet to sort of say, okay, can we cut this one out? Can we cut this one in half? Obviously, if we do end up pulling medications back, we want to recheck his heart function to make sure that things are staying stable. So it's a give and take. I think we're many, many years out now. And thankfully, we've had stable heart function through all of this, and we've been able to peel some of the medications off. And, ultimately, we're going to start thinking about the next phases where, as we get older, cardiovascular disease is the leading thing that we need to start considering, whether you've had a cancer diagnosis or not. And so, we think about basic things like lipid management. And fortunately, Lee is, again, active, not smoking, not overweight. He's doing all of the right things from a cardiovascular perspective. But those are the kinds of things that we're kind of transitioning more of our attention to.
Can I just build upon that a little bit? So you talked about, monitoring, maybe de-escalating therapy, but managing cardiovascular risk factors. What kinds of cardiovascular testing did you do or would you recommend? I think as oncologists, we're so focused on treating the cancer and the cancer's in remission and great, you're doing great, but we also don't think about that. We don't think about surveillance and cardiovascular imaging post completion of cancer therapy. So what were your thoughts around that? And what did you recommend in this case?
Yeah, I think for us, it was really the echocardiogram, which is the foundation of monitoring heart function, no radiation exposure, one of the less expensive tests that gives us pretty accurate information about overall heart function and pressures inside the heart. And so there's a lot we can tell from that simple test. And so I think around the time of transplant, we were monitoring pretty regularly. I mean, quite often, frankly, just to make sure that there was stability of heart function. And then we've started to space that out. There's more emphasis now potentially on being able to use biomarkers. So blood tests like NT-proBNP and troponin levels that can sort of be monitored in lieu of echoes, maybe every other year sort of thing to again, try to minimize the number of tests that we actually end up ordering. But for Lee, I think, frankly, the ejection fraction or the heart pump function is really critical. So echo has been really kind of the foundation for us. And we have kind of backed off. We were doing yearly echoes for a period of time, but now it's not nearly as often. mainly looking at, symptom, if we make a medication change, like if we stop one of his medications, then certainly within probably 3 to 6 months, we were checking an echo to make sure that his heart function was still preserved. The other piece of it too is, exercise capacity, I think, is also a really important piece to take into consideration. Sometimes folks will do cardiopulmonary exercise test, after cancer therapy and just after a diagnosis of cancer itself. As we've learned from a lot of folks in the exercise physiology world, there is a significant deconditioning to the body that occurs after cancer treatments and the diagnosis itself. And so kind of monitoring that. Fortunately, again, Lee is so active that, I think we hadn't necessarily needed to do that. But I think if, for example, he was, symptomatic, I think those would be helpful tests to kind of more objectively assess how his overall cardiovascular performance is.
Great. And I just want to go back to Lee and build upon the last point that you made, Vijay, about what have you done in your life post-treatment to try and maintain your cardiovascular health? Maybe, for those who are listening to this podcast who may have gone through cancer treatment, just maybe some pearls or words of wisdom about cardiovascular health and things you can do to try and improve that.
Yeah, just trying to get as much exercise as possible, live a healthy lifestyle, trying to stay away from fatty foods, and fried foods, et cetera. So I was not this time of year, we're middle of January, but I love cycling. So I do a lot of cycling during the warmer weather months. Right now, I am training for the Indianapolis 500 Festival Mini Marathon. So that's something I'm really excited about and looking forward to. That's the first Saturday in May, and it's really testing my body and my mind, and everything seems to be responding well. So it's just staying as active as I can, whether it's cycling outside, cycling on a stationary bike here at home, walking, jogging, hiking, just anything I can do to be outside and be active.
I think that's really important points. And I think it's also important to emphasize to individuals, you may not be able to cycle, but even walking, there are things you can do in the winter. And I'm in New York State now, so I do understand the
Me too.
cold, but it doesn't have to be necessarily running. It could be walking. It really could be anything where you're active. And you have to really think about what you as an individual can do, and importantly, what you enjoy doing. Because I think if you enjoy doing it, then you're going to probably be willing to keep doing it long term.
Absolutely.
So you have had a remarkable journey, and fortunately, you've done very well, thanks, I think, to the collaborative effort of many healthcare professionals along that journey. What take-home messages would you want to leave others who might be facing a similar path of dealing with, cardiovascular disease, cancer, and of course, all the issues related to the treatment? Any sort of take-home messages you can think of?
Yeah, there have been a few family friends or such that have gone through a similar path of mine, not with the cardiomyopathy, but with the cancer treatment itself. And my words are always just try and stay as active as you possibly can during the process. I mean, obviously, going through any type of cancer treatment, chemotherapy or radiation, it beats your body, especially the chemotherapy. I was leading up towards the stem cell transplant where they take you as close to death as you could possibly go before they do that. And it's just trying to remain active. For each stem cell transplant, my wife and I would do laps around the house, inside the house, because that was all I could do. But I did something. It's just staying up, staying active, keeping that positive mindset. Obviously, listening to your doctors because they know what's best for you. And my takeaway would just be try and be as active as you possibly can and pray feverishly.
I think that's so important because I think we've learned over the last several years that it's important to remain active because we do know that cancer therapy can be hard on your body, but also it can impact your cardiorespiratory fitness level in a detrimental way. So trying to be active is, you agree, very, very important. And I also think it helps you mentally, get through your cancer treatment and beyond your cancer treatment. Vijay, what lessons have you learned from this experience? I mean, obviously, challenging. As a cardiologist, you were sort of treating the cardiovascular health, but also introducing a stem cell transplant and all this chemotherapy also makes it very challenging. So what lessons do you think you can share with us that you've learned from this experience?
Yeah, it's interesting. When I met Lee, it was actually prior to us having a cardio-oncology program. So this was all kind of, I hate to use the word winging it, but we were just learning at that phase what to do, right? And so now, thankfully, there's so much information out there. We've learned a lot about stem cell transplants. The whole field of cardio-oncology has rapidly expanded and grown, and we've spent a lot of efforts through ICOS and others, educating the community about permissive toxicity and being able to work together with the oncology team and bone marrow team to try to get patients the best outcomes possible. And I mean, I think, this was just an early experience before all of this field really kind of came into being. And I think some of the things I learned is having an open line of communication, developing that friendship and trust with your patients, that you're going to be there no matter what. It's obviously harrowing to get multiple diagnoses at the same time. And it's very difficult for a patient to kind of comprehend that. And I just would encourage anyone who's helping these patients to really sit down, be present, be a good listener, let them know that we're going to get you through this no matter what happens. And I think that relationship is the key to helping navigate through the challenges of the treatments and, will ultimately lead to better outcomes. So I would say those would probably be the biggest things I would recommend.
Yeah, I mean, I think that's so important. And as you pointed out too, we certainly know more about cardiovascular health in individuals with cancer and cancer treatment, but we still have a lot to learn. And I think, not everyone has access to cardio-oncologists or cardio-oncology clinics. But what I think is important to note is they do have access to organizations like ICOS, where we can certainly try and help you, help individuals, help patients try and find those resources. And while there may not physically be a clinic in your city, certainly we're here to try and help you connect to someone who may help. So you don't have to necessarily be in a major academic center to access resources. I think it's getting that message out there too, that we want to help individuals no matter where you live in the United States, North America, or globally. And that's one of our sort of missions at ICOS, is to share that knowledge and to try and improve access actually for everyone who's facing, some of the issues that you faced during your treatment. So I just want to thank you, Lee, for sharing that experience. I just want to ask, are you still traveling as much? Because it seems like all these things kept happening when you were traveling,
Yeah. No, I retired at the end of the year, took an early retirement. And
Good for
so,
you.
yeah, thank you very much. So focusing more on everything I want to do, including being a lot more active in these things, that wasn't able to do when I was working and traveling so much.
Oh, yeah, that's great. And then, well, now you are kind of working, you're training, right, for an event.
Yes,
So I think you have just a different type of job now, training for that.
absolutely. Absolutely.
And Vijay, I want to thank you too for sharing your experiences as well. I think it's so important that we share this with the community to try and inform them as, the importance of working together and breaking down those traditional silos that we often see in medicine and talking to each other. Sometimes the solutions are not that difficult, but they're difficult if you don't talk to each other and you don't communicate. So I think that is also so much important. So thank you for joining us today. We've learned a lot from today's session. So grateful.
Yeah, just add my thanks to Lee, especially for opening up, being vulnerable, sharing your experience. It's always going to be inspiring to the medical community and just really in practical ways, very helpful for other patients who are facing similar things. So thank you so much for your time today. We really appreciate you sharing your story.
My pleasure.
Thanks, everybody.
Thank you for the opportunity.
Thank
Bye-bye.
you.
Thank you for joining us on this episode of Heart to Heart. And if you would like more information about any of the ICOS resources or opportunities, go to ic-os.org. That's ic-os.org for more information.